Hello guys, hope I'm audible and visible. If so, say me hi, hello, how are you? Hello, Martha and Avarma, good evening. So, good evening everyone. So, hope you're all gearing up for your Diwali preparation. And if you have your exams so near, I'm sure you must be hustling between celebrating Diwali, eating sweets, and also preparing, right? So, to make your university exam bit easier, is the FARRE series. I hope you must have downloaded the app and you must have got access to your micro pharmacology as well as pathology FARRE. So in the past two classes, what we have done in the FARRE and pathologies, we have completed the little bit of cell injury inflammation chapter, wound healing chapter, and little bit of your infection chapter, right? So with that note, today we are going to talk about neoplasia and genetics. Let's keep this conversation between us more interactive. So whenever I ask a question, I'm sure you must have read, right? So just say a few answers so that you get into the groove. So when you come to an exam hall, when you sit, these question and answering between us might definitely strike to extrapolate and write a better answer. Fine. So let's go on. That I'll be covering these topics: the benign and malignant tumors, hallmarks of tumors, the clinical features of malignancy, and also a little bit about the genetic Down syndrome and Turner syndrome, which are probable questions which can come in your university exam, right? Same thing, we are going to follow the same rule what you have been doing for the past two classes. What all questions probably can come as an LAQ? What all questions probably can come as a short answer question? If we have 2 3 mark questions, we'll include them whenever we discuss. MCQ, I'm sure we must have had a very adequate exposure for us to listen about the MCQs, right? So neoplasia is one place. There's a very likely possibility in the general pathology you can have a long answer question. Two reasons. One, it's a very long chapter, very big chapter. So easily it's possible for me to fit 2 or 3 long answer questions. That's the first thing. Second, it's about cancers. It's very easy for me to create a clinical scenario because most of the long answer questions in your pathology exams will have a stem, like a 15-year-old person came with so and so history. So there's a very likely possibility neoplasia chapter long answer questions can come in an exam. Fine. So what are the possible long answers that can come? So first thing, the molecular hallmarks. The molecular hallmarks is very, very important long answer. We'll try to quickly go through the 8 molecular hallmarks for us, which is important for us. Just few pointers so that you can add on to in your real exam, right? So they might given a classical history of an squamous cell carcinoma or a melanoma or random cancer, just to make sure it's a cancer. Then they can talk about what do you like the multi-step pathogenesis. The word multi-step pathogenesis or the molecular hallmarks means one and the same. So if it's given multi-step pathogens of this above cancer, write about all the molecular hallmarks you have, because most of the cancer go with the multi-step pathogens only, right? Second possibility, in a short answer question, again you have a difference between benign versus malignant. That's definitely a possible short answer. If not in a short answer, you might definitely get it in a viva, because they might have an specimen of leiomyoma, uterine fibroid, and they'll ask you how do you say it benign. What are the pointers for you to differentiate from benign and malignancy? You have to know about it, right? Then metastasis, the roots of metastasis, the lymphatic root, the hematogenous root. That's definitely a short answer question which can come, right? And you have your carcinogens. Carcinogens can happen in both short answer and I'm likelihood carcinogens can happen in long answer question as well. The reason why I'm putting carcinogens both the places, again, let's say there's a 60-year-old person with the history of hemoptysis and on a CT there's a 2 centimeter mass in the hilar region. Can anyone comment what type of cancer I'm talking about? 60 or 50-year-old, history of smoking, CT scan shows a 2 centimeter lesion in the hilar mass, in the hilar region. What cancer it is? Anyone? It's a very simple one, right? So the diagnosis here for me is a straightforward lung cancer. So if they put a lung cancer straightforward, good evening, Sushil. They can easily ask what are the pointers or what are the carcinogenic event or carcinogens which might have caused this cancer and enumerate a detailed note on microbial carcinogenesis, your radiation carcinogenesis, and also your chemical carcinogenesis, right? So there's a possibility it can come in a long answer as well as in a short answer, right? Then when you come to, again, there are a few clinical aspects. Paraneoplastic syndrome, I'm writing PNS for paraneoplastic syndrome, and also we have something in the terms of your tumor markers. tumor markers also, there's a very likely possibility that you can have questions on tumor markers as well, right? So these are the possible long answer questions and short answer questions which you can expect from neoplasia. Genetics, most likely they may be shorter ones like 3 mark or 2 mark questions. MCQs can come on genetics, the pedigree analysis. We have discussed detail in pedigree. If you missed that, please go to the MedEd app and have a look at the pedigree analysis. It's very, very conceptual and very simple, right? When you come to genetics, long answer questions, it's a bit unlikely to get a long answer question, but there are multiple places where you can get a short answer question. The chromosomal disorders, the Downs, which we'll be reading today, the Turners, which we'll be reading today, there's a very likely possibility that Downs and Turners might come as a short answer. Autosomal dominant recessive, Marfan syndrome can come as short answer, right? So there are multiple places. Maybe a complete note on genetic diagnosis. This also we have covered extensively in the MedEd app. Just go and have a look at it. We have divided the genetic diagnosis into cytogenetics and molecular genetics. And I'm sure that also makes much more sense to ask in a long answer because there are lots of genetic technology, karyotyping, there's FISH, there's your uh, RT-PCR, PCR, next generation sequencing. There are multiple things available in genetic diagnosis that can easily come as a long answer, right? So this is a snapshot of the neoplasia as well as genetic charter, which you can probably expect in your exam, right? So with this note, let's go on to today's topic. We're going to talk about the common MCQs or common 5 mark questions which you will encounter. Few of them, like you can see, benign, malignant, we'll start with that, and then we'll go to other important topics, right? So like I said in the start, beginning, even if you're very few of you, I want you to be as much interactive as possible so that it's a revision exercise for you. It's not a learning exercise here. It's definitely a revision exercise for you. Fine. Let's go ahead. So I'll tell you one point. You're going to tell me or comment which is benign or malignant, right? So I have a lesion which grows very slowly and progressively and does not invade the neighboring structure. Benign or malignant? Just comment B or M. That's more than enough. Comment at least one because still you have 50% of chance of getting it right? So something which is slow growing, insidious growth, and does not invade neighboring structure. Perfect. That's a benign lesion. So they do have a very slow growth, and they hardly invade the adjacent structure. When you say anything with respect to medicine or pathology, never use the term no. Nothing is 100% sure in medicine or pathology for the matter, right? Hardly invade, very rarely invade, right? Because the reason why I'm saying this is there's a condition called as pleomorphic adenoma in the salivary gland. Benign lesion, but it can have extension into the normal tissue as well, right? Malignancy, on the other hand, yes, they do grow rapidly, a rapid onset of growth. At the same time, most of the time, they do invade adjacent tissue. Invasion is definitely seen, right? We'll go with the same thing. Which of these two things will have cells which resemble the entire normal structure? No pleomorphism, nothing. Very well differentiated cells which resemble normal tissue. Benign or malignant? Obviously it is benign, right? Okay. In microscopy, you will have almost like hardly any pleomorphism. They'll be more or less normal looking cells and they will resemble the normal tissue. It's a benign thing, right? So if you have an lipoma, it's a benign tissue, benign tumor. I'll just have tissues which will resemble the normal parenchyma. That's all, right? On the other hand, differentiation is one of the important thing which might be lost in case of a malignancy. When I come to differentiation, there's definitely in microscopy, pleomorphism will be present. That is one of the important thing. The tumors will be pleomorphic. If you've been with me, if you've studied with me, what are the 4 classical features of dysplasia? Can anyone tell them? We talk about pleomorphism. We talk about higher NC ratio, mitosis, and loss of polarity, right? Perfect. So these are the 4 things which I can expect in any dysplastic growth. Definitely I can expect malignancy. So it will be pleomorphic and they might be poorly differentiated as well. They might not resemble your normal parenchyma or normal cells. Some of the malignancies are well differentiated. We'll keep that in the corner, but most of them will have abnormal pleomorphic cells, abnormal differentiated cell, and more mitotic figure, right? Again, next point. Which of these 2 tumors do you think will be very well encapsulated and can be easily seen away from the normal parenchyma? Which do you think will be very well encapsulated? If you're online, I want you guys to comment. Let's find it's fine. If you're wrong, it's completely fine. Which of these two tumors, benign versus malignant, will have very well encapsulated? Well circumscribed and encapsulation are classical features of benign lesions, right? Perfect, right? Good, Sushil. So encapsulation and well circumscribed lesions are classical features of a benign thing. I am not saying that all malignancies will have no capsule. They might have capsule, but generally they are invasive growth. They are invasive, they are irregular. If you remember reading melanoma, the ABCD, irregularity is a classical finding of a malignant tumor, right? They are irregular, they are invasive. Capsule might be present, might not be present. We need not go into it, right? Okay, good, Demiki. Okay, next part. Which of these two things do you think will metastasize, benign or malignant? Which you think will be metastasizing? Obviously, that's not a rocket science. Metastasis and tissue invasion are two classical features of malignancy, right? It will be present, right? Benign, they, we can here write never, but again, hardly is a better thing. They never metastasize. Because I do have few rare events of benign tumors which can spread, right? Perfectly. Okay. Malignancy will have a metastasis and malignancy will have tissue invasion, and a benign tumor will not have tissue invasion, right? Next question. If I'm going to surgically remove a tumor, which of these two things do you think can recur? Recurrence rate. It's common in benign or common in malignant? Again, B or M should be more than enough. Perfect. So post-surgical, you can write, see, treatment also I need a difference, right? Post-surgical, I'll come to it, meet. Be happy. Good evening. Post-surgical recurrence rate is rare. Here, recurrence is common. They recur commonly. Fine. Perfect. Okay, see, meet, there are two things which you have to remember. The term neoplasia or neoplasm is for benign as well as malignant. It is not always malignant. I have benign neoplasia, I have malignant neoplasia, right? Neoplasm or neoplasia. The term tumor again is a common terminology. I have benign tumor as well as malignant tumor. Malignancy means cancer, sarcoma, carcinomas. Benign, I have to mention as benign tumor. That's all, fine. Okay, those are different. They are not interchangeably used. They are totally different findings, fine. Okay, next. So terminology is also is very important since we are here. Hello Rajshri, it's fine. Good evening. So terminology are also important in defining benign tumor. Every benign tumor almost always ends with oma. Malignant tumors have a suffix of carcinoma or sarcoma, right? Those are the things. Those are the things, fine. Okay, perfect. We have ends with an ending with an oma, malignancy will have carcinoma and sarcoma, fine. Which of these two things, benign versus malignant, will require grading and staging? Do you need grading and staging for benign or malignant? Any tumor, grading and staging. Quite a few of you are online. I want you just to comment. Let's make it interactive. You make mistakes here, you'll definitely remember that in the exam, right? So grading and staging is important for a malignancy. It's not important for a benign lesion, right? It's important for sure. Okay? It's not needed. You need not grade or stage a benign lesion, right? Perfect. Okay, great. Super. Next question. Again, I want everyone here to comment on it. Which of these do you think you need just an excision treatment wise? Which of these do you think you need an removal of the organ? Which you think excision of the tumor is enough? Which you think an radical surgery or removal of the organ is required? Okay. Treatment wise, most of the benign tumor just needs excision of a tumor, right? Just the lesion, that should be enough, right? If it's a lipoma, just remove the lipoma. If it's a fibroadenoma, just remove the fibroadenoma. On the other hand, a malignancy, right? Perfect. A malignancy, you need almost always an radical surgery followed by either chemotherapy or radiotherapy, plus or minus. Chemo and radiotherapy is plus or minus depending on what tumor, what stage I'm talking about, right? So these are few differences between a benign lesion and a malignant lesion. If you follow Robbins, there must have been an image given in Robbins. If you can be representative, please go and have a look at it, right? I'll also help you in drawing that. Meet the difference between grading and staging. A very good question that can definitely come in a viva for you. Grading is a microscopic thing which is given to a tumor. When I have adenocarcinoma, if I have very well formed glands, I call it well differentiated. No glands, poorly differentiated. Staging is microscopic, gross, as well as radiological, as well as clinical, TNM. It involves a tumor size, it involves a lymph node involvement, and it involves a distant metastasis, right? So grading is something which is given by pathologist. Staging is something which is clinical, radiological, and pathology put together. That's the difference between grading and staging, right? Okay. Now again, diagrammatic representation will any day give you more marks. If you want to explain the form of a diagram, let's try to put here. You draw an uterus. I think Robbins also has some of the similar thing. Okay. In one side, draw very well defined leiomyoma. Okay. Other side, draw an extremely ill defined, maybe areas which are dark, little bit of yellow color area for necrosis to say it's variegated, and maybe you can put dots and say it has spread to a lymph node metastasis. Okay, you'll have parametric lymph node here, fine. So these representation will be eye catchy, that's all. If you're good in drawing, do that. Even if you're not good in drawing, you just need a representative diagram. You need not have a beautiful diagram. Never go for the beauty. It's a representation. You can write here very well circumscribed, well defined, encapsulate everything, ill defined with areas of necrosis and spreading. That gives an overall approach of difference between benign and malignance, right? Perfect. So that's the first thing. Next question which you're going to talk about is metastasis. And you are going to help me in metastasis. I'm just going to write whatever you're going to say, right? It's a revision session for you. I have 100% confidence that you will know everything regarding metastasis, right? Okay. Mets is seen in benign or malignancy? Start with the easiest thing. Metastasis seen in benign or malignant lesion? Obviously, it's seen in benign lesion, right? Perfect. Okay. So if I have to have metastasis as a definition, can anyone define metastasis for me in your own words? It need not be from Robbins. Not everything is going to be from Robbins. If you write in your own words, that's more than enough for me, right? Just define metastasis. Whatever comes to your mind. Definition. Definition of metastasis is the spread of the tumor which is physically discontinuous with the primary tumor. That's more important, okay? Which is a hallmark of malignancy. Meet, you're right. Hello, good evening, Kizir. Its distal spread is fine. A very distal spread is right term. But when I want definition, I want few classical words I'm looking for, right? It's a metastasis is defined as a spread of the tumor. What you said was right, okay? Spread of a tumor. You can write tumor or you can put part cancer. That's more than okay, right? Okay. And two sides, that's more important, that are physically discontinuous. That's very, very important. Okay. It's physically discontinuous with the primary tumor of origin. Okay. I'll tell you what do I mean by physically discontinuous here, right? Okay. I'll give an example for us to understand and to remember this, right? Let's take, I'm having an endometrial adenocarcinoma, a tumor in the endometrium. Let's just draw a uterus again. Let's assume there's a tumor in the endometrium. Here it's present here, fine. Okay, it's including the endometrial cavity. So when this tumor in the endometrium, slowly let's assume it goes to cervical region. Will I call this metastasis or extension? Mets or extension? Just extending because it's physically continuous with the tumor. At the same time, when it involves my lymph node in the parametrium, will I call it metastasis or extension? I call it metastasis, right? That's the difference. If there's a physical discontinuity, that word is very, very important. If you're being in a viva or an exam, write that and underline it. Metastasis is a spread of a tumor which is physically discontinuous with the primary tumor of origin. That's what we call as metastasis, right? Next is going to be roots of metastasis. So when you know metastasis, there are multiple roots of metastasis. Can anyone name the roots what you know? I'm sure, like I said, I'm sure you know most of the roots required for us. Tumors can spread via lymphatics. Tumors can spread via hematogenous spread. And tumors can spread into the body cavities, right? So these are the major roots for us. Lymphatic is one. See, when it goes into a lymph node, I call it a metastasis. Lymphatics is an invasion. I don't call, if I see in the lymphatics, the tumor emboli is just a lymphovascular invasion. I don't term it as metastasis. Okay, mate? The roots of metastasis, you can write lymphatic first, Though in your Robbins, it might be in a different order. I want you to follow this order. You can have hematogenous second. Perfect. Transgenome is also good. Third, don't miss this. Seeding into body cavities. Okay. Fourth, if you want to score an extra mark in your exam, add on to this special subtypes. Everything has special types. Some tumors may not follow any of these routes. They grow in a different way. I'll give you examples for that also. I'm sure you must have read about drop metastasis, which happens from a cerebellar tumor, right? And you have a tumor which is growing into the vein. Those are special type of metastasis, right? Med student, iatrogenic metastasis. What do you mean by iatrogenic? You mean that when you take a biopsy, it's pressed to the skin, iatrogenic? If that is a thing, generally we will do all the measures, make sure that it doesn't happen. And if it's going to happen, we'll ignore that. Be happy, bony metastasis is right, but that goes via hematogenous route. When I'm talking about a route, hematogenous, that's blood can take it to a bone, blood can take it to a brain, blood can take it to a lung. All of them are the routes of metastasis, right? Perfect. Now let's look at each of the route. So when I say lymphatic metastasis, you're writing just a theory university exam, right? You just need the salient points because the examiner is going to read your 5 mark question in maybe 1 or 2 minutes. That's all is required, right? So the classical points are required here, right? Tumors can spread from lymphatic vessel for sure along the natural route of drainage of the organ, right? So when you take a lymphatic spread, okay, you're taking a lymphatic spread, tell me which type of tumors go via lymphatic spread. Which type of tumors go via lymphatic spread? It is predominantly the carcinomas. Carcinomas prefer lymphatics, right? That's a thing. Be happy. Again, these exclusion might not always be true because renal cell carcinoma also goes to the renal lymph node, hilar lymph node, right? But yes, RCC and HCC has a different route, special route also, but they also go to a hilar lymph node, right? Predominantly is done by carcinomas, okay? And almost always it happens along the natural lymphatic drainage of the organ. Again, if you want to have a little bit of extra marks and extra points, the first site of metastasis in a lymph node will be the subcapsular sinus, because this is the place where the lymph node first, the tumor cells first reach, right? The first state of metastasis is going to be subcapsular sinus of the lymph node, right? That's an important pointer. Okay, there's one more information which I'm sure most of you must have known. What is the lymph node which first receives the metastasis called as? What is the name given to it? The regional lymph node which receives the first drainage, what do we call it? We call it perfect sentinel node, right? Perfect. We have something called an sentinel node. So this is a clinical application. So whatever we have talked about now is theory. That doesn't make sense for any doctor. If you know theory, I'm happy. Unless until you're able to apply the theory to practice, it's not good for us. That's not enough. Theory alone is not enough for us, right? Sentinel node. Sentinel node is the first node which receives, okay, which receives drainage from the organ, from any organ, from whichever organ it is. That's a sentinel node. Fine. Okay, meet. I'll come back to it very soon. There is a possibility it can happen. I'll talk about that as well very soon, right? The reason for having a sentinel lymph node biopsy is you can give an example that in breast cancer, I can assume that if sentinel node is positive for metastasis, the treatment should include axillary node dissection. You have to remove the axillary node if the lymph node is involved, right? Okay, if it is negative, that means the treatment can just be removal of the tumor. The primary removal of the tumor in breast cancers can be only mastectomy, right? That's the clinical application. You can just write bits and pieces. You need not write sentences, because when you write bits and pieces, the examiner definitely knows what you're meaning because they know whatever is required for you, right? Perfect. Okay. So meet and be happy. Whatever you are mentioning is nothing but skip metastasis. If you have time, do mention skip metastasis also. So there are possibilities that sometime, rarely, the tumor cells can skip the first node, that central node, and can go to the second node. We attribute the skip metastasis mostly due to technical error in doing a sentinel lymph node biopsy, right? That's what. But if you want to write, meet your question is this: if it escapes the sentinel node and goes to second node, we call it skip metastasis. There's nothing but when the tumor involves other nodes without involving sentinel node, right? If it involves any other lymph node without involving the sentinel node, I call it skip metastasis. This is one of the reasons that sentinel lymph node biopsy might fail, right? I hope meet and be happy. Your questions are sorted, right? That's about lymphatics. That's enough. Just 4-5 points is enough because I have three different types of thing. I have maximum 5 marks, right? So one or 2 marks for this definition. This carries 1 mark. Don't write more for 1 mark. That's enough. Simple and concise, right? Then hematogenous. Right? Just give me a second, guys. Okay, I'm back. Okay, let's go to the next one. Hematogenous metastasis. Fine. So when I take hematogenous metastasis, uh, perfect. I wouldn't say all sarcomas except, again, be happy. There's a way of presenting what you said was right. Rhabdomyosarcoma can have lymphatic spread. Doesn't mean that rhabdomyosarcoma will go to hematogenous route. Fine. Okay. Hematogenous, this is the most common route for sarcomas. Doesn't mean that carcinoma will not undergo hematogenous spread. Yes, they will. Carcinomas also spread via blood. Okay. Just write that also. Also spread via blood. I'll give you a simple example. Can breast cancer go to the brain? It can. Can it go to the lung? It can. Hematogenous only. Carcinomas do go to hematogenous route, but most commonly preferred by sarcomas. Fine. Okay. Next, like whatever Be Happy said, that's again an important point here. There are few sarcomas which go via the lymphatic route. Just write them. Rhabdomyosarcoma also goes via hematogenous. Whatever sarcomas we write also goes via hematogenous. But there are few sarcomas which prefer lymphatics, right? And second thing which is important for us, this we might have not much read when we are preparing for an entrance exam, but for theoretical exam this might be very, very important. What vessel do you think will allow hematogenous spread? Arteries or veins? Which vessel do you think will help in the spread via hematogenous? Arteries or veins? Mostly the tumor spreads via veins, right? They don't spread via artery because of the very thick wall of the artery. Vein is easy, vein is collapsible. Artery, as you intima, media, adventitia, it's a bit difficult. Venous spread is easier via hematogenous route as well. Perfect, right? When I say lymphatics, lymphatics is a drainage route, right? So lymphatics need not almost always go into hematogenous unless the load of the tumors in the lymphatics is so high, so it's not able to hold. They can spill over, and that can go to via hematogenous route. There is a possibility for that. Fine. Okay. Next. Third thing, if I'm having a hematogenous route, what are the organs which can get the metastasis? Because hematogenous is a route, it's not the end destination, right? So the destination of all the thing via hematogenous route commonly goes to the lungs or liver. Most of the tumors in the GIT, they prefer the liver, and something above the GIT goes to the lungs, because again, the primary reason is lung and liver are huge organs which very, very good amount of blood supply. Spleen, it's a bit unlikely, okay, because spleen, the blood flow is very rampant and the sinusoids are very open. It's not very good environment for it to sit and grow there. Fine. Okay. Bone marrow, yes, it can happen, but these are the common organs. Bone marrow metastasis is also possible. Bone metastasis is also possible, but these are the common ones which can happen. Fine. Next, there are few sarcomas, just to end it, which prefer lymphatics. So in addition to the hematogenous, there are few sarcomas which prefer lymphatics. Fine. Just few of them. Rhabdomyosarcoma is definitely one of them. If you remember the mnemonic, that will be much more easy for you to remember, right? So you have your synovial sarcomas. I'm not writing the suffix because everything here is sarcoma. I have something called clear cell sarcoma. I have something called as an angiosarcoma. I have R for your rhabdomyosarcoma. Okay. And E for your epithelioid sarcomas, right? So these are the sarcomas which can prefer your lymphatic routes. The mnemonic here is scare. Okay, you can remember that. These are scary sarcomas which can spread via both hematogenous as well as lymphatics, right? That's the third thing for us. So again, this is going to carry 1 mark to 1.5 mark maximum. That's the second biggest route. Third is your seeding into body cavities, right? Third major route for us, seeding into body cavities. So body cavity spread has multiple examples. It's just itself implied, right? So it's a body cavity. From the lung, it goes to the pleural space. From the heart, it goes to the pericardial space. From a GI tumor or ovarian tumor, it goes to the peritoneal space. That's just a natural cavity spread because they are seen adjacent, they go, right? So body cavity spread, it just spreads to the adjacent body cavity. So example, you can write a lung cancer to the pleural cavity and an ovarian cancer into a pericardial cavity, sorry, peritoneal cavity. I don't write generally or want you to write generally your cardiac cancer into the pericardial cavity because that's a bit rare. Cardiac cancers are not that common as your lung and ovary. So these are very prominent examples. Whenever you're writing body cavity, please don't forget to mentioning this point because most of the teachers will expect this in your answer paper. Pseudomyxoma peritoneum. Okay. So there's a condition called a pseudomyxoma peritoneum where it's a stage 4 tumor where the ovarian mucinous neoplasm or the appendiceal or the colonic, they can just rupture and entire mucin can spread into the body cavity. That's your peritoneal cavity. This can happen in a benign tumor of appendix or a malignant tumor, a benign tumor of ovary or a malignant tumor, because ovarian tumors of especially of mucinous origin can be of 10-15 kgs. They are huge. So the wall can rupture and it can spread all over, right? So there's nothing but, if I want to write in a word, it's intraperitoneal spread of mucin of mucin in case of your maybe appendiceal, because appendix is one of the commonest thing which can rupture because of the tiny size, ovary, or it can be colon. In case of appendiceal, ovarian, or colonic tumors, right? And the reason why I'm writing tumors and not carcinomas is, like I said, there's a possibility even a benign tumor can rupture and go, right? The fourth one. The fourth one are your special types. Okay? Be happy. The term Krukenberg's tumor, you commented on Krukenberg's tumor, right? Can anyone tell me which is the organ involved in Krukenberg's tumor? Because that's something which is important. I want to emphasis on that. That's why I'm asking. Satyajit, hamartoma is a benign lesion, right? A benign lesion very rarely is going to spread. Hamartoma is a benign tumor. If it becomes malignant, yes, it can spread. Krukenberg's tumor, the organ is ovary, right? Perfect. Stomach going to ovary or breast cancer going to ovary is called as Krukenberg's tumor. Fine. So Krukenberg's tumor, the long before thought was it has a transcoelomic spread. But these days, Krukenberg's tumor don't have a transcoelomic spread. It's a special type, so it don't involve in the body cavity. Put in a special type, right? So Krukenberg's tumor, which is an ovarian metastasis, the route of spread is here is retrograde lymphatics. That's the accepted spread. I'm putting that in special type because when I say retrograde, it is said that from a stomach, generally from a stomach, lymphatics goes to your celiac plexus and goes to your the celiac trunk in the via azygos and hemiazygos, right? But here, the tumor from the stomach will go retrograde and come to the ovary. That's an unlikely thing, a special type. A tumor from breast should go to the axillary node, but from the breast, it goes retrograde and goes to ovary. Again, it's a retrograde spread. A special type of metastasis add on to this, fine. Next is drop metastasis. Drop metastasis, it just drops. There's no spread here. Cerebellar malignancy, okay, like a medulloblastoma, spreading along the spinal column. It just drops. I have no step here. There's no step of metastasis. It's there high up in the posterior fossa. It just drops like that. Cells can break and drop and go to the spinal column. That's one more thing. Last but not the least, again, Be Happy has commented that before, calling about your HCC and RCC. RCC, maybe I'll write it here. Ignore this space crunch. RCC and HCC, they grow into veins. This is different from spreading into via veins. What happens is a renal cell carcinoma, it can grow into vein like a snake. Hepatocellular carcinoma can grow into the IVC, can even reach the heart. These are growing into the veins and not spreading via veins, right? So these are few special types which covers everything which is required for us to metastasis, right? I just go up. Structuring of a question is very important in university exam. Definition, let's root. If you want, you can draw a diagram. Lymphatics, few pointers which might carry 1 or 2 marks maximum. Hematogenous, few pointers which might carry 1 or 2 marks maximum. Body cavity, 1 mark. Don't forget the pseudomyxoma peritone. Special types is going to get you from 4 marks to 4.5 or 5 marks. That's all, right? So 5-mark question, please don't exceed more than 15-20 points. 20 itself is a stretch. Don't exceed more than 15-20 points. Beyond that, it's not worth it giving much time there. You can use the time in completing the other thing or thinking about and structuring how you're going to structure the MCQ, right? At the second part here, second question I want to discuss with you, molecular hallmarks. So the metastasis. Third one, we'll talk about molecular hallmarks of a cancer. Okay, molecular hallmarks of a cancer. If you've been with me in my classes, you must have definitely known about the story what we read about molecular hallmarks. I'll go with the story a little bit, and definitely we'll learn about the different types of molecular hallmarks, right? The story goes like this. This is a favorite story of mine. I love it a lot. Maybe if you are aligned with it, you can learn it also, right? So there's a mom and there's a kid, a big one and a small kid. Let's assume a 6-year-old kid. So the mom was feeding the kid normally. Every mother feeds the kid 4 to 5 times a day, right? A normal, superb thing. So this kid also was having 4 to 5 times food. The kid was happy and the kid was chubby and the kid was growing. The mom didn't want a chubby kid. So what the mom did was, let's reduce the food, right? New age mom, Gen Z mom, want the kid to be slim and sleek, right? Let's say that, okay, 3 times food. Okay? No offense to any mother, every mother is amazing, right? In spite of reducing the food, the kid was growing bigger. I don't know how to draw a chubby kid. Let's assume this is a chubby kid. Maybe the grandmother is feeding him, right? Then what happened is, it's fine. She was like, okay, the kid is chubby, it's okay. But at one point of time, the kid was constipated. So when the kid was constipated, automatically the mom was worried, right? Everything is going inside and nothing is coming outside. Constipation, especially with the kid, is a big concern. But they get constipated frequently, right? So when the kid was constipated, then the mom thought that let's go and treat the kid. Treatment for every constipation in the world is banana and water or banana and milk. That's what every mother must have done. You must have also done that. You must have also got that. You also will do that to your kid, fine. But Harrison says high fiber diet and fluids. Same thing my mom did. That's all. High fiber diet, banana, water. That didn't work. Then household remedies didn't work. Then they thought, okay, what we'll do is let's go to a pharmacist. No one goes to a doctor for constipation, right? Very, very rarely we go to a doctor. We go to a pharmacist. Pharmacist will give some laxatives, pop up that, and go take care of it. Unfortunately, went to the pharmacist, didn't work, right? Then only finally they'll remember, okay, we have a person who has completed like 5 years of MBBS, gave many, many exams, completed MD, DM, fellowship, and waiting for us, right? At the last, they come to a doctor. Unfortunately, when they come to a doctor, the kid is so huge and 50 kg in weight. Huge kid, 5-year-old kid, 50 kg in weight, and they're coming into you and they're asking you, doctor, help my kid. What will you do? What will you do? You can't keep mom like this, right? Okay, you can keep mom like this. What will happen? Obviously, you call it. Okay, either I call it a metabolic problem or I call it an idiopathic thing, right? So you just randomly call it, okay, a metabolic issue. Fine, that's all. Fine. So say a 50 kg kid, 5-year-old kid, 50 kg in weight, I call it a metabolic syndrome. Obviously, the mom was not happy with me. and went to alternative medicine. There's no demeaning to Ayush, Ayurveda, Unani, Siddha, or science. Homeopathy, I'm not going to talk about it. Rest, everything is pure science, not regulated science. Ayush person also said that I don't have any answer. So when they don't have any answer and the kid kept on growing so big, and the most irritating person in the life of the kid saw the kid. Who's the most irritating person in your life? Apart from me today, for me, it's always the next door auntie. Everyone in the world will have an auntie next door who will keep on asking you and your mom, what are you doing, right? Unfortunately, that's their job profile. And the auntie said, okay, there's a ghost in the home. Because the auntie just thought there's a 5-year-old kid, but such a huge kid, there's a ghost in the home. When you look at the auntie, automatically you become angry and frustrated. So you become red in color, right? Angry. Extremely angry at the auntie. If you're extremely angry at the auntie, I'm sure you must comment for this. Whom do you scold? The auntie or your mother? Whom do you scold? Obviously we scold the mother, right? So what happens is we were angry at the auntie. Next time when you're angry at the auntie, right, scold the auntie and not the mother. We obviously divert all our energy to the wrong person who loved you and just loves you forever in your life, right? So what you're going to do is next time onwards, everyone here, if the auntie scolds you or auntie gossips about you, go and tell to the auntie, look into your life, don't look into my life. Maximum she's going to tell you next time, arrogant kid, that's all. Anyway, she won't stop her job. So what the kid was doing is, kid became like this, so huge, and the mom is here, so tiny, because the kid has grown. So the kid broke everything at home, moved to the mom's place, sat on the mom, and killed the mom. This is the story of cancer. I'm going to compare everything in the story relative to cancer, which will cover all the classical hallmarks of a cancer. Fine? Okay, let's come to this. We'll go to the first thing. The kid was feeding 4 to 5 times a day. Kid was feeding 3 times a day. Whatever happened, the kid didn't stop growing. Which means, can I say this kid does not require food for growth? Yes, that's nothing but your proto-oncogene, right? So the first thing here is self-sufficiency of growth factors. Okay, thank you, Sachin. Self-sufficiency of growth factors, which means the tumor or the kid in this question does not require growth factor. It is self-sufficient. That's my first concept, proto-oncogene, right? Let's go to the next one. We're just going to compare this and write it, that's all. So here, we reduce the food. The mom reduced the food from 4 to 5 times a day to 3 times a day. In spite of that, the kid is not stopping the growth, which means what I'm trying to convey here is I tried to stop the growth, but still the kid is not stopping to grow, right? That's my second hallmark, which is insensitive. Okay? It's insensitive to growth inhibitory factors. Okay? The kid was insensitive to growth inhibition. Here is what we talk about, tumor suppressor gene. I tried to reduce the growth of the kid, but not working out. That's your the growth inhibitory factors, tumor suppressor gene, right? Let's go back to the story again. After the kid was still big, mom not worried, kid became constipated. I'm going to compare constipation to a stopping of a physiological process of excretion. Right? What stops cell death? Or what is cell death? What's a physiological cell death called as? Yeah, physiologically I have to excrete, that's stopping. What is the physiological cell death called as? Apoptosis, right? The next hallmark here is the apoptosis will be evaded, right? The next hallmark for me is evasion of apoptosis. The apoptosis evasion is the next hallmark. Comparing it to a constipated kid, constipation is stopping a physiological process of excretion. Here, stopping a physiological process of cell death is apoptosis. After the kid had constipation, pharmacist didn't work, banana didn't work, came to a doctor. The doctor called the kid a metabolic problem because it is 50 kg in weight, right? The fourth person here is about the metabolism. The metabolic effect is called as an Warburg's effect. I'll fill all of these very soon. Warburg's effect talked about the metabolism of cancer, metabolism of tumor cells. Any tumor cell, what we have, I need to have metabolism, right? The entire metabolism of tumor cell was given by Warburg. Okay? That's Warburg's effect, right? Next. So that's one here. Next year, after the Warburg said it and doctor said it a metabolic problem, the kid mother was unhappy, went to Ayush. Here I'm going to compare Ayush, that's in traditional medicine of India, to my strongest immunity which is available for me. So Ayush also didn't have an answer for this kid. So I'm just comparing that this tumor is going to escape even the hardcore immunity what we have, right? That's the next hallmark here. The fifth hallmark for me is in your escape or insensitive to your immunological surveillance. We do have a very good immunity, very powerful immunity. That also is not going to work here, right? That's what I'm going to compare with Ayush, right? Okay. They evade immunological surveillance. Okay. That's about the next step. So after this evading of immunological surveillance, the kid became so big, the auntie saw the kid and called the kid a ghost. Ghost, one thing is, ghost is like keeps on dividing a lot. That's what the ghost is, right? The memory of a ghost are all the Ramayana and Mahabharata series. Keeps on growing till the sky. Same way, a tumor will never die. That is taking care of your telomerase activity, or I call this then limitless replicative potential. That's my sixth hallmark. Then limitless replicative. It keeps on growing like a ghost potential, right? So when the auntie called me a ghost in the story, we became angry and red in color. Red color in my body is nothing but blood vessels. I'm going to compare the red color of the kid to the blood vessel, which is neoangiogenesis. Any tumor, if it has to grow, it needs new blood vessel for sure, right? Once neoangiogenesis is done, the last step is the kid moved from its place to the mother's place, spreading from one place to another without touch with the primary tumor is metastasis, right? So these are the 8 different hallmarks of tumor, right? So we have metastasis, neoangiogenesis, limitless replicative potential, evasion of your immunological surveillance, some Warburg, evasion of apoptosis, inhibition to your tumor growth factor, inhibitory gene, tumor suppressor gene, and cell signature growth factors, right? These 8 hallmarks, it's a 10-mark question. It's a long answer question. This is definitely coming a long answer only. If you write these 8 hallmarks, my first step is done. Okay? If you know all the 8 hallmarks, first step is done. Second, if I know one or two points, see, I am 100% sure that you must have crossed your first year exam by writing good amount of story. You know, one point, then you keep on adding on to it, right? There are 8 hallmarks here. That's the first point. Under 8 hallmarks, just 2 or 3 points for every hallmark. That's more than enough for you to extrapolate and fill at least 3 4 pages. That's enough for a 10-mark question, right? You have to be concise. Again, I'm saying don't write paragraphs, to the point, 4 5 points enough. That's more than enough for you to sail through the exam, right? Exams are the easiest one. I always used to say exams are something which no MBBS doctor should be worried about. Come outside. Our real fight starts when we have the patient in front of us and when you have to diagnose the patient and treat the patient, manage the patient, right? We are just getting ready for that. Internship will definitely make you ready for that with the existing knowledge. Let's go to it. First is self-sufficiency of growth factor. The self-sufficiency of growth factor, again, I'm going to talk about quite few important points. We have some genes called as proto-oncogenes. Again, terminologies. Proto-oncogenes are the normal genes which help in cell division. I'm not going to talk what are they. They are just few normal genes which help in cell division. That's all. Let's say a growth factor. Good evening, Dr. Manish. We have a growth factor. We have a growth factor receptor. We have your nuclear transcription factor. All these are the normal genes, right? Which help in the cell division. We call them a proto-oncogene. This is normal. So what for me, what is problematic is when the proto-oncogene becomes an oncogene. Oncogene is nothing but which causes cancer. Proto-oncogene does not cause cancer. Proto-oncogene is completely normal. Oncogene is nothing but it's a mutated proto-oncogene. Okay. Okay. So now you're going to tell me, you're just going to help me in this. Normal gene helps in cell division. It's becoming mutated. I'm having more cell division. So this mutation is gain of function or loss of function. Arya, I think if you're a 12th grade student, this is not the right time for you. Complete your NEET UG, come into MBBS, and I'm sure this will help you a lot. Gain of function, loss of function. It has to be an gain of function mutation, right? So every proto-oncogene here has to have a gain of function mutation only, because only when there's a gain, the function increases and more cell division happens. It's a gain of function mutation, right? That's what is related to oncogene, right? So every oncogene is going to either get activated, something like that, right? Now I know what is a proto-oncogene. I know what's an oncogene. I just need few examples. One or two example is very important. Hello, advance happy Diwali Nanda Kishore, right? Okay, so one or two examples are more than enough. If you remember, that's very good. I'm sure you remember more than 2 or 3 examples in proto-oncogene. I'll just ask you the question. You're going to tell me, and I'm going to write it, right? What's the commonest proto-oncogene mutated? Can anyone comment on that? Commonest proto-oncogene mutated. Anyone? It's RAS, right? RAS is the commonest proto-oncogene mutated. KRAS, you can see them in colon. This came in this year INICT also. Pancreatic cancer, you see them in pancreatic cancer. You see them in lung cancer. That's one. If you remember breast cancer, we do 3 markers. ER, what's the third one? We do ER, what's the third one? That is HER2/neu, right? HER2/neu is a proto-oncogene which is seen in case of breast cancer. And I'm sure everyone must have known this. What is a translocation seen in case of CML, chronic myeloid leukemias? What translocation do you see in chronic myeloid leukemias? Perfect, right? Translocation 922. In this, I have a thing called as BCR. That's a proto-oncogene which happens in chronic myeloid leukemia, right? That's more than enough. So again, this, if it's an essay question, let's say 10 mark or 15 mark question, right? 8 subdivisions. Each of them is going to carry 1 or 2 marks. That's all. So this is more than enough for a 2 mark. We know what's a proto-oncogene. We know what will happen when it's mutated, how it causes cancer, and we've given few examples for the same. Fine, perfect. Let's go to the next thing. Next thing is it's insensitive to your growth inhibitory factors. Here I'm going to use a term called as tumor suppressor gene. Here you need not write what is the function here because it's self-explanatory. It's tumor suppressor gene. They're going to suppress tumor formation, or in other words, they're going to inhibit cell division, right? That's a normal function here. So when the tumor suppressor gene are going to get mutated, they will result in a cancer. Okay? I'm going to ask you a question. I want you to answer this, right? Who is online, please answer this. The normal function of this gene is to stop cancer formation or to suppress tumor. This gene is mutated and I'm having tumor. So this mutation should be gain of function or loss of function. What do you think it will be? Gain of function, loss of function. Perfect. It has to be loss of function mutation. It has to be loss of function mutation or it has to be deletion. Right? Either loss of function or it will cause deletion. That's what is going to result in a tumor suppressor gene. Right? Second point. Again, I have 2 alleles. This concept is very important. Examiner will look for that for sure. I have 2 alleles of every gene. One allele is lost. Other allele is still functional. Can this stop tumor formation? Yes, obviously it can. So when do you think the tumor will come? When there's one mutation or when there's both the mutation? Only when both are gone, right? Perfect. This calls us Knutson's 2-hit hypothesis. This is very important. Do mention about this, right? Yeah, Knutson's 2-hit hypothesis. The name is important. So Knutson's 2-hit hypothesis said biallelic, that's 2 allelic mutation is must to cause cancer with respect to tumor suppressor gene. Without biallelic mutation, you will not have a tumor suppressor gene induced cancer. It has to be biallelic mutation only, right? So these are few pointers. Again, few examples. Few salient examples. One is retinoblastoma. As the name says, it causes retinoblastoma. That's one. And it causes osteosarcoma. That's the other one, right? Next, P53. If you want to get more marks, write that retinoblastoma is an governor of cell proliferation. P53 is an guardian angel of the genome, right? If you want, add on to it, right? P53 It's mutated in case of your most many cancers. Just on a broader aspect, right? Leukemia, breast cancer, you see p53 quite frequently, and CNS lesions, gliomas. That's also a very prominent tumor suppressor gene. At least mention these two. If you have time, just write a little bit about how a retinoblastoma functions and how a p53 functions. Retinoblastoma sits in the G1S checkpoint. The checkpoint, if it's gone, everything goes to the next stage, becomes a cancer. p53 controls every mutation across the genome. That's why we call it guardian angel, right? So if the p53 is gone, no one is going to control or take care of the mutation. Errors will keep on accumulating, results in a cancer, right? Next, you can write CDH1. CDH1 is mutation seen in lobular carcinoma of breast and your diffuse gastric cancer. CDH1 is nothing but your E-cadherin loss. Okay, this is also a very well-known example. Write about them. Next, write about APC. Don't forget APC, because APC as a tumor suppressor is known to many people. Most of the examiners will expect APC. APC gene is your adenomatous polyposis coli, seen in case of familial adenomatous polyposis. There are a few examples. There are multiple examples. I'll tell you last statement. With that statement, you can 100% remember many examples, right? The statement is important. Maybe it might fetch you an extra mark because this statement is something is not given in Robbins, but it's important holistically. If you know this, you understood your tumor suppressor gene concepts, right? So most of the tumors, most cancer syndromes involve tumor suppressor gene. I'm writing TSG for tumor suppressor genes, right? So if you remember this, you can remember n number of examples. Can anyone online here name me few cancer syndromes? I'll give you an example: BRCA1, BRCA2, hereditary cancer syndrome, right? Like that, can you anyone mention at least one cancer syndrome? You have a cancer syndrome where you have lots of uh, lesions all over the body, which might have capiolate spots. What's the cancer syndrome called as? I'm sure you must remember that, right? Not paraneoplastic syndrome, Ajit. I want cancer syndromes. Paraneoplastic syndrome is a clinical symptom, right? I'm asking about syndromes of cancer. Have you heard of neurofibromatosis? You must have heard of neurofibromatosis, right? That's a cancer syndrome. Von Hippel-Lindau syndrome is a cancer syndrome. Peutz-Jeghers syndrome, cancer syndrome. Eaton hematomatous syndrome, Cowden syndrome, cancer syndrome, right? So all these cancer syndromes will be tumor suppressor gene. So if you write this, you can add on to this examples much more. Write Peaton, hematomas, Peutz-Jeghers polyp, STK11LKB1. You can write them. DHL, von Hippel-Lindau, TSC1, tuberous sclerosis. You can keep on expanding that, right? This is a final nail. So if you write this, it's understood that you understand the concepts of tumor suppressor gene. That's more than enough for me, fine? Next is about evasion of apoptosis. That's the third hallmark. How a constipation we related to that. Here, a physiological process of cell death is stopped. That's how it produces cancer. So evasion of apoptosis, one is must for me, other one for an extra mark. So here, when you have mutation in respect to BCL2, BCL2 is an anti-apoptotic gene, right? So more and more function of anti-apoptotic gene happens, which happens in classical case of translocation 1418, which is seen in case of follicular lymphoma. So this gives an holistic understanding that yes, you know about follicular lymphoma, which is a hematological neoplasm, and there I have translocation 1718. In that patients, you will have overexpression of BCL2, more expression, more and more anti-apoptotic gene. Cells don't die, they keep on accumulating and results in a tumor. Second thing, if possible, write this: mutations in FAS gene. So if you remember the first class, what you look in FARRE, where do you read FAS? Can anyone remember and tell where did you come across FAS, FAS ligand, FADD, all these things? Where did you come across? Extrinsic pathway of apoptosis. You remember? BCL2 is in the intrinsic pathway of apoptosis. FAS is in the extrinsic pathway of apoptosis, right? So mutation is FAS. results in a condition called as ALPS. ALPS is an autoimmune lymphoproliferative syndrome that also a cancer syndrome which happens in FAS gene mutation, right? Just two examples for evasion of apoptosis. This is self-explanatory and I just give you two examples, that's all. Next we'll come to the next one where the doctor called the kid a huge kid. So there's a metabolic problem there with the kid, right? That's what we call as a Warburg effect. So altered cellular metabolism is Warburg effect, right? So what happens exactly in Warburg effect and what is required for us for understanding? Simple. So Warburg's effect said that tumor cells consume glucose only via aerobic glycolysis only. That's important. They consume glucose via aerobic glycolysis only, which means they don't go into citric acid cycle, they don't go into electron transport chain. Fine. Hi again. So if they don't go into electron transport chain, the number of ATP produced will be less. But why Warburg is essential for every cancer is if they stop at glycolysis, the byproducts of glycolytic pathway will end up in producing having more nitrogen, more carbon, which will be converted to nitrogen. If you remember biochemistry, there are few reactions which will convert carbon to nitrogen. So this nitrogen forms the basis of DNA and RNA. Because for a dividing cell, I need more DNA and RNA than carbohydrate and energy, right? So this results in increased cell division. So this is the basic understanding of Warburg's effect. For time related, I am writing it horizontally, but you can go vertically so that it can occupy good amount of space. Fine. Hello, Dr. Ansi. Hello. Fine. So this is what is about Warburg's effect. It takes glucose, stops at aerobic glycolysis, takes the carbon, pushes to nitrogen, produces more DNA and RNA, which results in more cell division. That's the base of it, right? The gene called as MYC gene. MYC gene is the master regulator of Warburg's effect. Please mention this, that's important. MYC gene does everything which is required for Warburg's effect to be successful. Right? That's the gene. So I know what is the process. I know what is the gene responsible for that as well, right? Only one thing extra will add. So this completes Warburg's effect for me. But like I said, if there is no clinical application, it's very difficult for me to apply it to a real-time patient. Application is the most important thing. Theory is not that important for me, right? When it comes to application, investigation called as PET scan or PET CT, okay, which helps in secondary diagnosis or metastasis diagnosis is based on Warburg's effect. Okay? Warburg's effect is the basis for PET CT. So I have a clinical application for it. So this is the reason that Warburg was given a Nobel Prize, because with this effect, we came to understand that I do have an investigation which can help me diagnose secondaries even before they are clinically relevant, right? So even before being clinically relevant, I can diagnose them. That's the base of Warburg's effect, fine. Now let's go to your immunological surveillance. How does a cancer escape immunity? Because immunity is the most powerful thing what we have, right? But cancer is just like that escape immunity. How do they escape immunity is my question. Mechanism of evasion of immunological surveillance, right? I'll just give you just name pointers, few classical names, headings, maybe subheadings little bit, so you can extrapolate on them, fine? The first and the foremost thing is they will, maybe you'll use A for it, down regulate. They down regulate MHC1 complex. Okay, that's one of the important thing. Down regulation of MHC1 complex. So if MHC1 is less, can a CD8 T cell identify them? They cannot. By this, they escape CD8 T cells. Because only when MHC1 is there in a cell, CD8 can even identify them, right? So they escape CD8 cells. It's a direct relation, that's all. Second is they increase the expression of PD1 or PDL1 and CTLA4. Brackets, right? These are immune checkpoint activation, right? They increase them. So these are immune checkpoint. So these are being increased. By increasing the immune checkpoint, the cell tells to my body, I'm a self antigen. If you remember immunology, you can easily correlate that, right? So by increasing CTLA4 and PD1, a tumor cell tells to my immune cells, I'm a self antigen, don't destroy me. By this way, they can escape CD4 T cells. That also is done. At CD8 T cell, at CD4 T cell, that's been done. Right? Next, what happens is third, have something called an antigenic variation. Okay? So when I say antigenic variation, one easiest concept what we can relate to antigenic variation is COVID. When COVID came, your newspapers must have told every now and then, every 1 month, 2 month, new variant, alpha, beta, delta, epsilon, multiple things, right? That's variation in the virus. So the reason why there's a variation is COVID came to me, my body developed an immunity, COVID mutated, immunity gone. Same thing happens here, right? There was an tumor cell, my body created an antibody against this, about to kill the tumor cell changed. So I cannot kill, right? So this escapes your antibody related damage. B cell or an antibody related. Same like COVID. Tumor cells also escape by producing antigenic variation, right? That's the third one. Last but not the least, have something called tumor heterogeneity. Okay? So tumor heterogeneity is not exactly to escape the immunity, but to make sure that immunity is not so powerful, right? I'll just give an example of tumor heterogeneity. Let's assume I have a virus like this, uniform. I produce an antibody, I destroy it. That's all. As simple as that. But I have a tumor with 1,000 cells, and each of the cell are different. I cannot produce one antibody, and my body cannot produce 1,000 antibody. So it's very, very varied. If at all my immunity is successful in producing something to destroy them, they destroy 2% of the cells. 98% still divides, multiplies, produces 100 different variations in a span of a month. So it keeps on changing, heterogeneous. So my immunity cannot target them and destroy them, right? So these are the 4 simple steps by which a tumor can escape an immune response. We know, we have studied in detail in the MedEd app. If you're starting, I won't urge you to go to the MedEd app. This will just give you an overview of how to present it here. Down relation of MSC1, increased expression of PD1 and CTLA4, and your antigenic variation and tumor heterogeneity helps you to escape the immunological surveillance, right? The next one is an limitless replicative potential. It's self-explanatory, right? Limitless replicative potential. So here is due to activation of telomerase. It's an enzyme, right? Enzyme activation. So when telomere is activated, this will make sure there is reduced or nil telomere shortening. Reduced or a nil telomere shortening. Because of no telomere shortening, obviously it will have an uncontrolled growth. Because telomere, if you remember your biochemistry or in the first chapter of Robbins, telomere is something which will keep on shortening with cell division, and at one point of time they become very small and they die. But here it doesn't happen. It cannot shorten, it'll keep on be longer, tumor cells don't die. Just add on one more point here. Telomerase expression is generally a final step in carcinogenesis. In most of the carcinogenesis, this telomere expression is a final step, right? It's not an early step, it's a final step in carcinogenesis. Do remember that as well, right? Okay, that's something which I want you to remember, right? So we know about the 6th hallmark. The 7th hallmark is very simple, new blood vessel. And neoangiogenesis is something which is very common and which you have to know, right? So neoangiogenesis, first point and the foremost point is, it's not a late step. It's a very, very early event in pathogenesis. It's a very early event. Even before the tumor becomes like 2 millimeter, neoangiogenesis start. 2 millimeter, not centimeter, very tiny, right? So how neoangiogenesis happens is same like what we studied in wound healing, same concept. New capillaries keep on coming. And the reason for this happening is there'll be more amount of pro-angiogenic factor. There are two pro-angiogenic factor, VEGF, the most important one, don't miss them, and beta subunit of fibroblast growth factor, right? These are two. Angiopoietins are there, vasculopoietins are there, but these two are important for me. And there's a less amount of anti-angiogenic factor. So here there will be less amount of vasculostatin, okay, or angiostatin. Again, self-explanatory. Statin, it's going to stop, right? So these becomes less. So totally, there's more amount of pro-angiogenic protein, which increases the blood supply, neoangiogenesis. More blood vessel, obviously it will help in more growth, right? That's a concept here. The last but not the least is metastasis. We read about metastasis in the 5-mark question, right? So if you feel at the end of writing all 8 of the hallmarks, if you feel your explanation is short, add on to the different routes of metastasis. But actually what I'm going to explain here is not the root of metastasis, we're going to explain the step of metastasis. So what happens here first is, the first step in any cancer is, first is invasion of basement membrane. That's first. Once you invade basement membrane, as there's such a big tumor, entire tumor cannot go to a lymph node or to an organ. It has to break. Second step here for me is it's mutation or destruction of or loss of E cadherin. We have loss of E cadherin. It's a cell addition molecule. So one cell comes outside. Only one cell comes outside. The rest of them are still there. That's the second step. So once I have the loss of E cadherin, the third one is it goes and destroys the stroma or extracellular matrix. The entire stroma is destroyed. So I have a space for the cell to move. A cell cannot automatically move. So for that, I need something called an EMT because it's an epithelium, right? Epithelium cannot move. It has to change to mesenchyme because only mesenchymal cells have actin myosin. Only muscle can move. Skin cannot move. Unless they move it, skin cannot move, but muscle can move like that, right? So it's epithelial to mesenchymal transition. That's EMT. So once a cell becomes from an epithelium to a mesenchyme, it can automatically move. So it moves slowly and steadily and it reaches your blood vessel. In the blood vessel, you have tumor emboli. There's a tumor emboli formation in the blood vessel. It forms an emboli and moves either in the lymphatics or in the blood vessel. After that, we have something called an chemokine mediated exit. To exit, you need chemokines. Because only a chemokine can tell, please come to a lymph node, there's not good enough space for you to grow, or to a lung, or to a brain, or to a liver, right? And after that, it forms an metastatic clone. The metastatic clone goes to the organ in which it is involved, be it a lymph node or a distant metastasis in an organ. It forms a metastatic clone here. Okay? So this is in short the steps of metastasis. Just 6 pointers. Again, this is a long answer where this is one of the part. If metastasis alone is asked in detail, so then you have tried how does loss of E cadherin happen. Then you have in your MedEd notes that you have something called a driver mutation, passenger mutation. Who destroys stroma? Macrophage destroys stroma. So add a note on that. What is EMT? What are the genes involved? Twist and snail. Add on to it. Tumor emboli formation. What is required? The organization of an emboli and how it helps. Which chemokines helps given time. And when it comes to metastatic clone, we have few pointers. Every match will be multiple, well defined. I'll have feeder vessel, central necrosis every point. Add on to it, expand it. But if it's a part of an essay where there are 8 points, this is more than enough. Because here, this one of the 8, maximum it's going to carry 1 or 2 marks. Don't keep on writing everything what you know for 1 or 2 marks. This is more than enough, right? Let's go up. So we have read every hallmark of cancer in a very short form. Remember the story? The only purpose of the story is to make sure you remember all the 8 points. Then you have cell signature growth factor, proto-oncogene, define them, how it's mutated on oncogene, give an example. Tumor suppressor gene, define them, How do they cause cancer? Define them. Please don't forget Knudsen's two-hit hypothesis. Add on few examples. Don't forget, right? Most cancer syndrome are by tumor suppressor gene. If you write that, you can add on more examples than to this, right? Evasion of hypothesis, just two examples. Need not define because that's taken care of. You already know it, right? Hi, Darwin uncle. Warburg's effect. Tell what is Warburg's effect? How it helps in the growth of the tumor by producing nitrogen, DNA, RNA. NYC gene is the one which controls everything, and the practical application of Warburg's effect, it's involved in PET scan. Fine. Okay. Evasion of your immune surveillance. You have direction of MHC, increased PTLA, PD1 and CTLA4, and you have antigenic variation, and you have tumor heterogeneity. These are the ways by which it can either escape or make sure it nullifies the immune response, right? Then we have limitless replicative potential. Telomerase activation keeps on dividing. That's all fine. As simple as that. Neoangiogenesis. HA is hypoxia inhibiting. I don't know what. Expand please, HA. Right? Early event in pathogenesis. Reduced and anti-angiogenic and more pro-angiogenic. Fine. And meds. We have all the 6 steps of metastasis. HLA. Perfect. Fine. Okay. Okay. So the metastasis, invasion of basement, right? So this covers in short all the 8 classical hallmarks of a tumor. Fine. Okay. I'll just go to the next thing. I wanted to cover something in a genetic thing, so that also be helpful for us. Yes, Burkitt's. See, you can write about Burkitt's in Warburg if Warburg is asked a 5 mark. But if it's a part of an essay question, limit yourselves. Right? That's what I've been saying. Right? Let's have a quick look at Down syndrome. Down syndrome, I feel you need to know the clinical features of Downs. The pathogens of Downs is required, and obviously you have to start with what is the problem in Down syndrome. Can anyone tell me what is the genetic problem in Down syndrome? What happens in Downs? What's the mutation? Anything? Simian increase is a symptom, right? I am asking the molecular problem. Downs is the most common chromosomal disorder. You can start with that if you want, right? It's the most common chromosomal disorder known to mankind. Downs is not inherited, Downs is acquired, right? That's one. In Downs is nothing but trisomy 21. Okay, Downs is trisomy 21. That's the problem in Downs. Perfect, right? 21st chromosome is 3 times trisomy. Okay, so now we have made sure that we know what is a Down syndrome. Second question for me is perfect, like what Silver Screen said. I need to write in what all ways this trisomy 21 happens. There are actually 3 different subtypes, 3 major subtypes which I want to know. One is definitely non-destruction of chromosomes. Completely understood. Silver Screen snapshots. Nice name. Meiotic or mitotic. Because whenever you write something, be very, very, very specific so that there is no leeway. Even a Viva, they should not ask you a leading question. Complete everything in a single line so that they are left with that, right? Okay. So when you come to the pathogens of Downs, there are few things which are required. Okay. Before going to pathogenesis, can we talk about the risk factor of Downs? Because Downs, like I said, it's not an inherited disorder, it's an acquired disorder. What's the risk factor of Downs? Great, Darwin. So you're doing good. Risk factor of Downs is the increased maternal age. Right? So increased maternal age is risk factor. Generally, more than 35 years, we consider them a risk factor for Down syndrome. Fine. That's an increased maternal age. That's a risk factor for Downs. Fine. Perfect. So because this is the one which is going to relate us to the next point. The most common pathogens of Downs, which is seen in approximately 95% of patients in Downs, is like what Silver Screen said. It's non-disjunction but meiotic. Meiotic non-disjunction of chromosomes. Okay, that's more important. Yeah, you're right, Darwin. The reason why meiotic non-disjunction, and most importantly, this happens in maternal chromosomes. It's actually maternal meiotic non-disjunction. The reason why it's maternal is the age. The difference between male and a female's gamete is ovary forms its primary oogenesis as a fetus. It will be stopped till the woman attains menarche, then it restarts again. So which means the age of the ovum for a 35-year-old mother is 35 years. It's an old ovum. It can have errors. But on the other hand, to a guy, spermatogenesis starts only after puberty. Let's assume 15 years. So only after that spermatogenesis starts. So a 35-year-old man's sperm is only 20-year-old because only after 15 years it starts. But on the other hand, mother starts at the fetus, intrauterine life. So it's an older ovum. That's why maternal meiotic non-disjunction is more important than paternal. That's why mother's age is risk factor and not dad's age, right? Second one. Second one, which happens in approximately 4% case of Down syndrome, something called an Robertsonian translocation. This is the pathogenesis, right? So Robertsonian translocation is very, very less. It's just 4%. But Robertsonian translocation, please write this. Don't forget this. It's very important. Maternal age is not a risk factor. Okay? It's never a risk factor. Maternal age is not a risk factor for Robertsonian. If you have a Down's baby to a 25, 26-year-old mother, think of Robertsonian translocation. So then explain what do you mean by Robertsonian translocation, right? It is translocation. If you can put an extra word, that will be great. It's an unbalanced translocation. That's the reason we have Downs between two acrocentric chromosomes. It's between two acrocentric chromosomes. It's an unbalanced translocation. And the most common translocation is between translocation 14 and translocation 21. Okay, that's the commonest translocation. It's between two acrocentric. Acrocentric has a very, very, very big Q arm and a very, very, very tiny P arm, right? It's an acrocentric chromosome, right? It's an unbalanced translocation. No risk factor of maternal age. It's a random translocation which can happen to any mother at any point of time, right? Third case of Down syndrome, seen in 1% of the case of Down syndrome, it's mosaics. Mosaics are post-zygotic error. The random error, the post-zygotic error after the formation of zygote, if some of the cells have a trisomy error, chromosomal error, it continues from there on, right? So these are the pathogens of Downs. So once I know the pathogens of Downs, then I have to talk about the clinical features. Then obviously we'll have a tiny word on diagnosis as well. Prenatal diagnosis required for us. We have to have a word about that, right? Clinical features, Darwin has been helping us for a long time. Clinical features is undoubtedly the most common cause of intellectual disability. Darwin, I want you to just change the term. The term mental retardation is not being used, it's been removed from medical curriculum. So we use the term intellectual disability. Because it's not fair for us to call someone retarded, so it's an intellectual disability. That's the most common cause of intellectual disability. Fine. Okay. Second, there have been lots of classical clinical features. Simian crease is a finding. Again, simian crease might be seen in a normal patient. So when I say it's a clinical feature, like there's a clinical feature of mongoloid slant, it can be seen in many other patients, including Downs. I can have problems in the heart, congenital heart defects, congenital GA problem, hypothyroidism, leukemia, Alzheimer's. These are all increased things, right? So you can have facial features. The facial features, the mongoloid slant. Okay, that's important finding. It's mongoloid. It's a very classical finding, right? You have a unique finding in skin, the simian crease. I'm sure you know what is the simian crease. These are classical findings. Maybe seen in Downs, maybe seen in other people as well, right? Organ dysfunction, congenital heart defects, your ASD, VSD, they are common in Downs, right? Gut malrotation is common in Downs. Leukemia, there's an increased risk of leukemia. I want you to mention Alzheimer's. If possible, write an extra note on Alzheimer's also. Okay. The reason is there's a gene called as APP, amyloid precursor protein, that is there in chromosome 21. That's why 321, more deposition of amyloid precursor protein results in Alzheimer's, right? The increased risk of Alzheimer's, leukemia, and everything. So this gives me a clinical feature. Yes, increased risk of acute myeloid leukemias also, right? Both ALL and AML. That's why I mentioned just leukemias, right? So I have clinical feature I have pathologist. Now I have to diagnose patients. Diagnosis of Downs, the most important thing for me is prenatal diagnosis. Because once the baby is born, and for me to diagnose, it's not that difficult. You can diagnose clinically and do a karyotyping and diagnose them. If the diagnosis is made prenatally, before even the birth of the baby, the mother and the father can collectively take a call whether they want the baby or not. That's very, very important, right? So in diagnosis, prenatal diagnosis is important for me. There are multiple things with diagnosis, fine? Okay. Easy time, I don't know. You have to ask the physics wala person, right? Yeah, the enzymes are very important. So when I say prenatal diagnosis, there are multiple things here. One, you have an ultrasonogram of an increased nuchal translucency. Okay. The increased nuchal translucency is the first starting point because that's the earliest thing you can do. 8-9 weeks you can do. The skin fold here will be a bit more thicker. Radiologist will definitely come and talk to you about that, right? So once I have increased nuchal translucency, then I have two ways here of going forward to the diagnosis. The most commonly approved is the one which I'm going to do in the left. The recent update I'm going to write in the right, right? Then you have test, okay? Your triple test, your quadruple test, everything. So these are enzyme tests which is done on the mother's blood. I'm sure you must have read that in OBG. It's an enzyme test. Take a few enzymes, take a screenshot of that and diagnose it, right? Then again, this is just suggestive of Downs, not diagnostic of Downs. Then I have to do an amniocentesis or an CVS stands for chorionic villus sampling. It's a villi I take from the baby's thing, right? So chorionic villi sampling. So when I take a chorionic villi sampling, then I do a karyotyping. So this karyotyping will confirm Downs. So confirmation of Downs happens only after you get the genetics. The rest everything are helpful for me to think about it. Yes, PPEA and inhibin, there are a few more enzymes as well, right? So this is the routinely done one because I need a baby's genetics to call 100% Downs. But this is a bit expensive. At the same time, it will be delayed time as well, fine? Now let's look at the other part. The other part, the reason one, which I want you to remember, I want you to include in your exam paper also is, I have something called a non-invasive prenatal testing or screening. Okay, so we call this NIPT or NIPS. PS stands for screening, PT stands for testing. That's all, right? So this is very, very important. The only reason it's non-invasive, I don't touch the baby. Because in the other part, I need to take an amniocentesis or chorionic villus biopsy. Only then I can diagnose. And is much early, right? It can be done very, very early. I use maternal blood. You take maternal blood and look for cell-free fetal DNA in the maternal blood, and then do the same thing. Do a genetic test for diagnosis. Okay. So NIPT or NIPS is very important from a doctor's point of view. Earlier, cheaper, and accuracy of 99%. Sensitivity specificity of 99%. So that gives a very good time for the parent to think whether they want to abort the kid or not. Because I cannot give like 1 week or 2 weeks and say, please take a decision whether you want abortion or not. This gives you an answer by 10th or 11th week. It gives easily 5 weeks or 1 or 2 months to take a call whether they won't have a baby or not. And if they decide early abortion obviously will have less complications, right? That's about your Down syndrome, right? So I want to, I'll just put a break here. Just go back to your FARRE in your app. The FARRE will be available for everyone. You just click, go to home screen, the second year column, click on the FARRE. You'll have all the micro, pharma and path things available. Read them. These are the commonly asked questions in university exam. I'll cover more or less one or two, maybe more than half of what is there in the FARRE book. in the lectures of FARRE, and rest of them, please have a complimentary reading. If you miss something at any point of time, if you have doubts, always ping me on Instagram or Telegram channel. I'll be more than happy to help you. Fine. NIPT is done in the around ninth week. We can do it from ninth week to 10th week, Darwin. Okay. So if there are any doubts, do let me know. If there are no more doubts, let's call it a day. I'm sure you guys generally don't have doubts, right? Okay, let's call it a day, and hopefully we'll learn many more things together. And for everyone, advanced happy Diwali and enjoy Diwali. Have a colorful year throughout. Right? Thank you. Bye bye.